Hi, today I would like to present some updates from the ASAS online case library. Let me share my screen. Here you see the main page of this educational project. Starting from beginning of this year, we are publishing every month a new case dedicated to a specific problem of differential diagnosis of axial spondyloarthritis. And starting from yesterday, you can access the new case of the month directly from the main page. As shown here, you see ASAS case number 23 is just published, and this case is dealing with a 35-year-old female patient who came to us with a question whether or not back pain is related to axial spondyloarthritis. Here you see the main characteristics of back pain. The pain started slowly around 10 years ago, so there is already long-lasting history of back pain. Pain improved with exercise. There was no clear improvement with rest. There was night pain with awakening, especially in the second half of the night. Patient reported about morning stiffness for 16 minutes and longer. There was no alternating buttock pain. I hope you agree with me that overall, this picture really resembles the picture of true inflammatory back pain. But inflammatory back pain, as you all know, doesn't necessarily mean that there is inflammation behind this pain, but this is a very important starting point to start thinking about potential inflammatory explanation of back pain. And this is a young person with inflammatory back pain, where we should certainly exclude inflammatory nature of this back pain. Other characteristics you see here, there was no sufficient response of back pain to NSAIDs, although ibuprofen was not taken in the full anti-inflammatory dose. There was no family history of spondyloarthritis, no peripheral manifestations, but there was an extramuscular skeletal manifestation, plaque psoriasis, which has been diagnosed by a dermatologist, and currently plaque psoriasis is quite well controlled with topical treatment. No other extramuscular cell manifestations like uveitis or inflammatory bowel disease. If you click further, you can use those buttons or pictures on the bottom of the screen. You can see the results of the clinical examination. There was some tenderness over the right sacroiliac joint. Sacroiliitis objective tests were positive, but also the sex sign was positive on both sides. There were no limitation of spinal mobility, no other disease manifestations. In the lab, HLA-B27 was positive, CRP was rather normal, and in the lab there were no abnormalities otherwise. So we have an overall case which is suspicious of axial SPA or axial PSA, so a young patient with inflammatory back pain and presence of psoriasis. And we, of course, would like to confirm the inflammatory nature of this problem by application of imaging. In this case, X-ray of sacroiliac joints was performed first. And what you can see here, you see some abnormalities on both sides. So especially on the left hand side, you have an impression that there is some subchondral sclerosis, maybe even joint space abnormality, joint space widening. And on the right side, you cannot really follow the joint space very well. In this case, you might get an impression that there is a high-grade sacroiliitis, but you are probably aware that X-ray of sacroiliac joints is neither very sensitive nor specific, and that is why the overall trend goes in the direction of doing advanced imaging like MRI already early in the diagnostic process. And the best choice in this case, if we suspect axial spondyloarthritis, would be an MRI of sacroiliac joints, if we have a differential diagnostic question and pain is localized in the lumbar spine, so the lumbar spine would also be helpful. So in this case, we have MRI of sacroiliac joints and spine. Let's start with this sequence. This is a semi-coronal plane T1 weighted sequence. You see that the water in vertebral disc and in the spinal canal is dark, the fat is bright. So this is a sequence where we would be looking for structural changes. And here we see clearly that there are no structural changes. So everything what we saw on X-ray was in fact just a normal anatomical variation, and the X-ray positivity was a clear false positivity. In this case, there are no structural abnormalities in the sacroiliac joints. And if we look now at STIR sequence, you recognize this sequence on bright water and dark fat signal. There are also no abnormalities in terms of active inflammation. So there is no bone marrow edema, no osteitis visible in none of the aspects of sacroiliac joints. You can also put both pictures together, and if they are linked, and the majority of cases they are linked, you can look at STIR and T1 weighted sequence simultaneously. You have here also some additional sequences or planes, and they are axial planes, which are helpful. They are not obligatory. The main recommendation would be to do T1 and STIR in semi-coronal projection, plus an additional erosion-specific sequence. But semi-axial plane might be helpful if you have some structural or active inflammatory lesion and you would like to recognize what is the exact anatomical localization of this lesion. Is it ventral part? Is it dorsal part? It might be relevant for interpretation of those changes as inflammatory or mechanically induced. So what you see here, again, no abnormalities on T1 and STIR. In this case, patient brought also an MRI of the spine, and this is an MRI that is frequently done in the case of suspicion of degenerative disc disease, for example. And here, you will see now the particular feature of this MRI. There is no clear water-sensitive sequence. So there is no STIR or T2 weighted sequence with fat suppression. What you see here on the left-hand side, you have T1 weighted sequence. Water is dark, fat is bright. And you have a T2 weighted sequence without fat suppression, because both water and fat is dark. Of course, you can use those sequences to screen for abnormalities, active inflammatory and structural changes. For example, active inflammation would appear as a bright signal on T2 and dark signal on T1, but in this case, there are no abnormalities of that kind, except some degenerative changes of intervertebral disc. You see this disc looks quite normal. It is bright, it is water-rich, but this disc is degenerated, dehydrated, and the same as also here. You see also a small protrusion here, minor abnormalities. The clinical relevance of those abnormalities is rather unclear, but there are no active inflammatory or structural changes. So let's summarize this case. Here you see a summary page where we're discussing all the findings and put imaging data in the context of clinical information. In this case, we need to say, first, we had clinically suspicion of axial spondyloarthritis, but then we could not find a correlate for those pain, for those symptoms especially. We couldn't find any signs of inflammatory spinal and or sacroiliac joint involvement, and this would result into exclusion of axial spondyloarthritis or axial PSA in this case. We observed some minor disc abnormalities with rather unclear relevance. That is why, in this case, we would make a diagnosis of non-specific back pain and then follow up this patient as such. And final remark, this case illustrates very nicely that X-ray of sacroiliac joints might be sometimes misleading, especially if you see some changes, suspicious changes looking like high-grade sacroiliitis. In some of the cases, you still need to question those cases, and more reliable way would be to do advanced imaging. So this is all about this case. I hope you enjoyed this discussion, and thank you very much for watching, and see you next month.